I hope everyone is fine. Today's lesson is going to be on HIV and AIDS under the nursing syllabus. That is, actually, HIV and AIDS is something which is commonly known. It has affected us or infected us in a way, and so we are living with it. Most probably in the society, in the economy, the society and the community at large. So the greater apex of what you want to enlighten today is the immunity system and how it relates with HIV. So we just have to start by taking some few steps, analyzing and studying the core and the aspect of HIV in detail. So most probably we need to know the basic concept of HIV/AIDS, how the global national HIV statistic epidemiology run, the basic combination prevention intervention, and how HIV positive living is entailed. So we know the acronym HIV stands for human immunodeficiency virus. It is the virus that now causes HIV infection, and then later on it changes to AIDS, which now weakens the immune system by destroying the cells that fight against it. So that is that. We know it's preventable, manageable, but is not curable. Transmission by exchange of body fluids like blood, breast milk, semen, and vaginal secretion, but they are not transmitted again by kissing, hugging, shaking hands, sharing personal objects, foods, or water. HIV will now first start by invading helper T cell, and we'll see this one through our today's topic. So these are just the basic immune cells of the one's defense, may give the mechanism of defense to a person. So no signs or symptoms of illness, but are still infectious to other during the initial stage. Then it changes to symptomatic, and where now we have the signs. So HIV positive mother to a child at pregnancy, that is one of the other mode, can also get that one. You can be infected by HIV. So let's check on the HIV prevention. Key approaches like individual can reduce the risk of HIV infection by limiting exposure to risk factors. Combination prevention use as HIV prevention approaches like one, combination HIV prevention intervention are defined as combination of mutual reinforcing one, biomedical measurements, behavioral, and social interventions. So when you start with biomedical, those are the ones to do with health things like condom use, right? Elimination of mother to child transmission through the EMTCT. That is why in the MCH department we have the PMTCT, VMMC, voluntary male mutilation circumcision, methadone replacement therapy, STI treatment, blood safety, behavioral interventions. That is inclusive of the transmission aspect. When you transmit into blood, we're supposed to do the screening thoroughly first, and then we still have structural changes. So apart from that, you also need to know behavioral changes like communications on social grounds, structural intervention as well. And then social protection like transfer for orphans, vulnerable children, COT or VP. That is that. So away from that, which is very, very summarized in a way, we don't want all these. All these are not necessary, but if you want to read them, just come and go to the Medical Students Arena website and click program, select your course. Actually, this is in 1.1 nursing, and then you'll get this one. So that is that. Away from that, let us also handle these bits of this one a bit, and that is something to do with the modes of HIV transmission and the risk factors. This one is important because some of us will use myths and relate them and use them as if they are real. So mode of transmission, for example, in Africa, mainly it is heterosexual, to mean that male having sex with the female. And though we have homosexual included when men have sex with men, but not female with female, though that is also homosexual. But that doesn't encourage lesbianism, because as much as you don't practice sex in any way, as fluids are not being exchanged in details, but remember, whatever you're using during that act can interfere with the sterility of your body. So other infection can still come in, because sepsis is not perfected. So no consensual sexual exposure, assault, parenteral through injections like intramuscular injection, intravenous injection, transfusion of infected blood or blood product as well can result to that. Exposure to infected blood or body fluid through contaminated shafts like intravenous drug use as IDU. Donated organs, when somebody donates for your kidney which is not screened for HIV virus, yeah, and then it is implanted into you, and that is another case of transmission. Traditional procedures like the piercing of the ears by the Maasais, these tattoo things from the traditional inheritance, those ones also, if you don't check on the sterility of the instrument are used, therefore you can be risking yourself of that. We have perinatal or vertical transmission method. So for example, the first one, that is when you talk about perinatal, is before birth, so when the baby is still under the inside the uterus. So we have transplacental, that is from the mothers to the via the placenta, during labor, especially the obstructed labor or prolonged labor, during delivery, and if at all, at most, the predisposing factor comes in when it is breech presentation, right? And also during breastfeeding. Normally we have guidelines whereby, for instance, we have purely or exclusive breast milk, then we introduce winnowing and it remains winnowing without breast milk. So that guidance and advice is supposed to be followed by positively living mothers to prevent the breastfeeding in transmission. HIV is not transmitted by casual contact, so hugging is not a problem. Surface contact, shaking hand is not a problem. From insect bites, sharing mosquito bite is not a problem. Let's check on the biological factors influencing HIV transmission and the disease status of the source patients. So related to degree of immunosuppression and viral load, these are just things or factors that can influence virals infection in you. Not only HIV/AIDS, can be even influencing hepatitis B or hepatitis virus, can be Ebola, can be so on and so forth, any other. So one, the degree of immunosuppression and viral load. The more your immune is suppressed, the more you manifest the disease status in details. Right? So, and again on the basics of the disease status of such patient is that high risk during primary infection and late disease when viral load is very high. So when you are at high risk of transmitting the diseases to the other people, like your sexual partners, is normally at that moment when you first contract the disease. So at that point, the virus first are elevated in your blood, and so you are at high risk. And then during when your viral load is very high as well, that is at the latest stage of the disease. Another thing is higher or lower the CD4 count independent of viral load, and then the presence of untreated STI in source and person at risk. Presence of untreated STIs like gonorrhea will increase chances of infection, maybe in male partner. So that is to mean that when you have ulceration of the chronic herpes on on your penis, and then when you engage, this one is going to be like you are more of exposed than somebody who doesn't have gonorrhea with a complete intact skin of the penis. Both ulcerative and non-ulcerative STIs, that is like typical ulcerative is here, the cancroid, the genital herpes, and the non-one like condylomata, all those ones, they can still give you a factor as a predisposer. Related to high viral load in genital secretions during STIs and the disturbance of genital mucosa as well can predispose that. And that is that circumcision status can also influence whether you're circumcised, because uncircumcised men 4 times are likely to acquire HIV infection than circumcised. Gender difference susceptibility, female genital anatomy presents a larger surface area with more of target cells than the HIV required to gain entry. So when you talk about the social economic factors influencing HIV transmission, we'll be checking on social mobility, global economy, HIV and AIDS follow routes of commerce, partners living apart. Yeah, partners living apart is a key thing. Your girlfriend is in Migori and you are in Mombasa. And you know the hormones do misbehave and so on and so forth. At long last, the distant relationship, at most, they don't work. And if they work, some people practice, but I think it's hard they work. It's a myth in a way. Even in a week, there is always that sag and depression in the gradient of love between the two people who are staying apart. So this one, absence and all that, right? Absence will now bring founder in, and then at long last you find on cheating or somebody working on a different ground. So by then, that is another thing. So partners living apart, another thing. Stigma and denial and silence in the norm, blah blah blah. Those ones you can read at your own time. They're very important. Still talk about the multiple sexual pattern as one of the behavioral factors. Multiple sexual partners, unprotected sexual intercourse, large age difference as well, right? So factors not associated with the risk of transmissions what you should consider, these are not important, like they are not attributing to any transmission risk. Insect bites, they will never cause HIV infection. Saliva, like kissing, up to some maximum amount. So yeah, but it's not encouraged. I know nowadays you guys enjoy kissing than even any other thing, so you don't do it in a very shadowful way. Sneezing or coughing, yeah, doesn't cause the shared skin contact like hugging, doesn't shared use of facilities like toilet, doesn't bring anything. Key population of the groups who do to specific high risk behaviors are at increased risk of HIV irrespective of the epidemic type or local context. They often have legal and social issues related to their behavior that increase their vulnerability to HIV, like HTS should be routinely offered to all key population every 3 months. So retesting, and at least that is testing actually. So retesting at least annually is recommended for all clients of key population. More frequent voluntary testing may be beneficial depending on risk behavior. And then you have vulnerable population. These are people who, due to situations that comes beyond their control, they are at high risk of getting infected or transmitting, accessing, vital HIV service, etc. So where applicable, these persons should also be encouraged to be tested with their sex partners. These include widows and widowers, orphans, vulnerable children, families, children living in the street, young women aged 15 to 24 years, servicemen and women, their family, refugee, displaced person, migrant, people who abuse alcohol, etc. And then vulnerable population, these are persons still the same, and I've already given you that, it's a repetition of the same. Another key people who are typically very key in population are survival, sexual and gender-based violence. Clients who reported sexual violence should receive that test at the first contact, and they should immediately be referred to clinical evaluation, documentation, treatment and trauma counseling, and initiation of post-exposure prophylaxis. Survivors who test negative should be retested after 4 weeks, and if it is still negative or discordant relationship, retesting should be done at 12 weeks. Now that is away from what we were to tackle, and so this is now what we are going to do at the moment. So the key thing, that was just a launch up. So here is what we are going to do over, and it's a very key thing that you pay interest. And if you're watching over you with YouTube and not audios, still the same. Avoid any disturbance. Just pay maximum. So let's have this: the immune system. Immune system and HIV/AIDS. That was the lesson of today. So definition of terms. The first thing you need to understand is what is immune system. Actually, it's a system of special cells composed of lymphocytes and the monocytes, the proteins, that is in bracket antibodies, tissues, organs, and that defend the body against foreign substances, antigen, germs, microorganism, HIV, etc. So look at this system of special cells. Lymphocytes and monocytes are white blood cells, but now on the ones which are now not polymorphonucleated, but they are mononucleated in a way that the monocytes, some of them lack granulocytes, or maybe the granules. And so like lymphocytes, we have 2 types of lymphocyte, and you really need to know where they live and where they stay, and so where they're also being produced. And so their main role, apart from the normal general role of white blood cells, they also have some specific role that distinguish them from the granulocytes, like the eosinophils, the basophils, and the neutrophils. We have proteins like antibodies. They always fight antigens which comes and roam around without any permission in our body. So we call them the foreign antigens. So the foreign antigens are always being squarely beaten by the antibodies. Tissues and organs that defend the body against foreign substances are also playing a role. So when I say antigens, it just simply means the germs, the microorganism, like for example HIV antigen, right? So let's talk about antigen. Antigen is a foreign substance which, when introduced into the body, will stimulate the immune system to respond by producing antibodies. And then antibody, on the other hand, is a protein substance produced by lymphocytes and deposited in blood, and they bind to specific antigens. So that is all about those 2 main terms that we are going to handle: antigen and antibody. So you get antigen is a foreign substance, then antibody is your own substance now, which tries to fight for your survival, for your safety. Okay, so introduction to immune system. This is the body's protective mechanism and response to infections. The organization of immune system immune system response is organized into either three: innate immunity, cellular immunity, and humoral. The immune system, so when I just want to give like innate is the obvious immunity that we've got, like the barriers of skin, the mucus secreted on the wall. They try to fight in a way like mucus will trap dust when you breathe in. Yeah, the skin will protect you from any entry of microbial. Yeah? The hair on your nose will trap dust. Yeah, so those are innate, right? They are direct. They are the first immune. Then we have cellular. Then you have the humoral. So we are going to check them in details on later ground, but again we have a special course or maybe subject that entails all this. When you go and do general pathology, you'll get to see this one when you're doing the immunology. So that is that. The immune system is organized into organs, tissues, and cells. So the organ involved in the immune system are categorized into two: primary organs and secondary organs. In the primary organs, we call them the primary lymphoid organs, and they compose of thymus, which is just hapo karibu na trachea. Tuko na bone marrow. The bone marrow is inside your bones. And then we have the secondary lymphoid organs, which are the lymph nodes. The lymph nodes are located in several parts of your body. In the cervical region, that is in the neck region. In axillary region, that is under your armpits, you will find them, and on the groin or between your thighs, that is in your pubic region. So those are the lymph nodes, right? So that is that. Okay, so let's proceed. Whatever you're able to view from your hand, is a diagrammatical presentation showing the structure of secondary lymph node and primary lymph node. I'll try to zoom it so that we can have a bit of clear presentation, diagrammatical presentation. I hope you're able to see it. This one here, not yet zoomed accordingly. I wanted to zoom it than this. I hope now it's adequate. We can see what it entails. Now it's unzoomable, it's still small, so we don't need to give it that. So let's proceed. Now away from that, let's have on what we refer to as the function of the primary lymphoid organs. They also can be called the central lymphoid tissue. They serve to generate mature lymphocytes from the immature cells. So they are like the ones to produce the lymphocytes, right? Yeah, the B lymphocyte, the T lymphocytes, and therefore they'll provide a place of training for the lymphocyte, so that the lymphocyte can be used to the memory of the body's diseases actually, and then when any other strange disease comes, they learn from that, they train, so in a way that if the disease return, they can now perfectly outmatch the disease. Secondary lymphoid, again, they can also be called the peripheral lymphoid tissue, and then the lymphocyte now here they interact with the antigen, and they can produce more cells during that event. It also provides a home for lymphocytes where they can be available when they are needed. So away from that, let's talk about the cellular response to HIV infection. Once HIV enters the body, the anti-HIV antibodies and the cytotoxic T cells, that is the first thing, production is initiated. Then macrophages and dendritic cells binds virus and present it to the CD4 cells. And the CD4 cells are located in those Primary and secondary lymphoid tissue can be in the lymph nodes, can be in the thymus, can be in the spleen, right? I want us to have this. We have all these dendritic and macrophage cells all over in the mucous most region, like in around the penis, around the vagina. They're ever there. So instantly, let's talk about heterosexual transmission. During the process of coitus, the victim who is actually negative, maybe having sexual relationship, the coitus with an infected person. Normally, if you are a male, your penis has got the macrophages and dendritic cells. So that happens in that. If you're a female, your vaginal lining has got the macrophages and dendritic cells. So when they are exposed or during sex, they normally come up due to that friction and rubbing, because they sense like there is a danger. So they are always there to protect it from any attack, or for anything can be pathogenic or mechanical. So if it happens, so they will be readily available. So when they meet around the HIV virus, they'll take it as a foreign particles and combat as usual. Take it in, bind it like any normal condition pathogens, and take them to CD4. So instead, CD4 cells are supposed to work like a CD4 cell, but this time HIV is very smart. It attacks the CD4 receptors and the CD4 at large. Yeah. So when that happens, they control now your immunity instead of you controlling them. So let's proceed. So the T cells are the prime target for the HIV attack due to CD4 receptor. Other cells with the CD4 receptor are macrophages, glial cells, Langerhans cells, chromaffin cells, etc. So the cellular response to HIV infection, and the other very important is what we're going to check here. So the very important thing, so when CD4 are attacked, they are going to misbehave, and I'll tell you how that happens. So let's check on the cellular response to HIV infection. One, the other very important cell in HIV infection is CD8 plus T cells. The CD8 plus cytotoxic cells, immediately they have seen presence of HIV infection, they will lyse HIV infected cells. Zitajaribu kuharibu, zivunje the HIV infected cell. They'll be destroying the infected cells so that they don't retain them in the body, so that they can infect other cells. So by that, they destroy your cells. You see, again, they will secrete the cytokines, and the cytokines are what now manifest with the increase in temperature, the pyretic condition, and that's why you see for an HIV victim, you present with high temperature, fever, right? And chemokines also will be secreted that will inhibit virus replication and block viral entry into CD4 T cell, because CD4 T cells is the main target. So the CD8 plus cells are just but trying to evade the attack, but by that they missed by doing unnecessary events and action, a cascade which end up even killing your cells. So development of the CD8 T cells is crucial for control of HIV replication. But now a question is, why are CD4 T cells depleted by HIV? CD4 T lymphocyte is the main target of HIV. And HIV infection leads to low level of CD4 plus T cell through three main mechanisms. One, they'll try to directly kill the infected cell. The virus will kill the infected cells. Second, they'll increase the rate of apoptosis. And when you remember apoptosis, when you did pathology or general pathology on cell injury and cell death, you realize we have three ways of cell dying, either through necrosis, apoptosis, or through, I've said either through necrosis, apoptosis, or autolysis. Autolysis is after you are dead, so the body decomposes by autolysis, it digests itself. But apoptosis is just a cell program that our cells normally die, like red blood cells, they die after 120 days, so it's a program thing, right? So when this one is initiated, it is increased, the infected cells will die even before their real death, but that is just to kill the CD4. So HIV tries to kill the CD4 by all these means. It can also does that by killing of infected CD4 plus T cells by CD4-8 cytotoxic lymphocyte that recognizes infected cells, and I told you that one in the above line. Let's talk about the humoral response to HIV. Remember, humoral is the largest immunity of your body, and it evades the infection by use of antibodies mainly. So the humoral immune response involves production of specific antibody in response to HIV infection, non-neutralizing antibodies to HIV structural proteins like the protein 17 and 24, and neutralizing antibodies specific to the proteins are produced target, and then when they are produced for the variable region of glycoprotein 120 comes into play. CD4 binding sites and chemokine receptor also comes into play, and then the transmembrane protein, the antibody specific to the transmembrane protein glycoprotein 41 also come to play. Away from that one, let's check on how cellular and humoral responses come into play. In HIV infection, both cellular and humoral immune responses combine and play important role. Initially, cellular response are initiated, followed by antibody responses 4 to 8 weeks after infection. Cells play the major roles in production of antibodies. Mutation in such a case will result to HIV glycoprotein rendering antibodies ineffective. So this diagrammatic presentation, what you are able to see from your hand, is a CD4 plus alpha inducer lymphocyte, which is a primary target for HIV attack. Hiyo ndio targetiwa. So, but in case of HIV presence, this is what now happen. There will be production of cytokines leading to 1. Macrophage activation, so that they can kill intracellular bacteria and tumor cell, because your body now try to evade the condition of HIV. The B cell will proliferate and produce plasma cell antibodies production, which will try also to clear infecting organism, but by that they'll be also killing your cells. T cells memory clone will form a clone of T cells so that it can confuse the virus. You know, the virus will be also following T cells. So if the cytokine produce a clone of T cells, they will be confusing it. It will assume that the clone are the original T cells, and which is not the case. So another thing is that the CD8 cytotoxic T cell maturation will enable killing viral infected cells and tumor cells as well. So that is that. Immune system progress, I've talked about this one, talk about that. So let me go to the next page and see what is there. So proceeding on the same, but now almost over. You can see this is a pathway of how the HIV cascade is progressive in a way. So see, we have from your hand, if you're able to see, we have the R5 strain of HIV entering. Immediately it enters. We have the XO strain as well. So they penetrate mucosal exposure to HIV 1 type quasi-species. They will enter in the mucosa, and immediately they enter there, they use the CCR5 receptors, and the CCR5 receptor, that is selective infection by R5 strain, always attached to that, and they will enter into the dendritic cells, and the dendritic cells, as one of the first immunity which are roaming around, they will go directly and reach the CD4 lymphocyte, which will be like, oh, I can handle you. But instead, that is not the correct thing. The HIV is smarter than the CD4 plus lymphocyte. So the CD4 will carry it and take it to the lymphoid tissue, be it the lymph node, and on the arrival, after the fusion of the dendritic cells and the CD4 lymphocyte, they will be transported off virus to the lymph node. When they reach the lymph node, the HIV now will start misbehaving with them. They thought that, oh, we are smarter, but now here they realize that they are no longer smart. So HIV will start to misbehave with them, and then the spread of the infection to the activated cell, HIV will now start to misbehave with them, and then the spread of the infection, they will say that the R5 enters, and then after the R5 enters via the exposed place, they will bind to the dendritic cells, and then the fusion of the dendritic cell and the CD4 lymphocyte is now compatible for transportation, and so they will be also transported to the neighbor lymphoid tissue, that is lymph node, and then the spread of the infection to the activated CD4 plus lymphocyte will begin. Entry of virus infected cell into bloodstream will start, and then there will be widespread dissemination, and that will lead to organic infection. This duration is not always tomorrow and today, it is a duration worth years. So it can start today and end up lasting for quite a duration. Transient symptomatic illness is another thing. That is immediately after infection, then it affects 40 to 90% of HIV positive individuals. It involves a lot of opportunistic diseases. It ranges from mild non-specific illness to severe illness that can result in hospitalization. First, 44% of people will present with adenopathy, that is in swelling of the lymph nodes due to the activity which takes place there, those immunological reactions, the HIV and the immune cells reactions that will enable the lymphoid tissue to hyperplasia in a way. Pharyngitis, that inflammation of the pharynges, headaches, rash in your body, then you have muscle pain, the myalgias, lethargy, sense of fatigue, and extremely low in terms of energy, fever due to cytokines being released, that is fever coming into play due to cytokines. Yeah, so at last then we're gonna have assembly the HIV protein together with the copies of HIV's RNA genetic material assembled to new virus, and the newly assembled virus will bud, that is reproduce out from the host and attack other cells. So maturation, the new virus budding out, mature into virus that can now infect new nearby CD4 cells. So that is that, and that is when now the HIV drug, the antiretroviral comes in, both the protease inhibitors, the non-nucleotide reverse transcriptase, the nucleotide reverse transcriptase, the fusion inhibitors, all those ones, they come into play, and that is where now we get them. In this diagram you see how those misbehaving, we normally chop them off from that root. So that is calling the end of our lesson today on the HIV/AIDS, the immune system, and so you can wait and have other lessons. Always when you're using the YouTube, it is good to use the YouTube because you see also the notes, and so don't forget to subscribe. You're very many, actually you're over 2,000, right? So you're over 2,000 right now. I'm wondering why your subscription is still low. So that is that. Thank you, and this is Dr. Uma presenting.